Hello, everyone. Thank you for joining us today for our webinar, listening session, stakeholder engagement, conversation, however you want to call it, for residential habilitation, group home, and family home habilitation services. So welcome. And I also wanted to let you know that in the room with us, we have Director Tony Newman and we have Jordan Grant, our policy unit manager. We have some of our stellar training team is here. Caroline Hogan is on the call. And we're here to engage with you, answer questions, and try to really get some stuff done today. So I'm going to move on to the next slide here. Again, just starting with our mission statement for senior and disability services. We like to think it's important that we read this and remind ourselves, our stakeholders, our partners, all of us, why we are here to do this work today. I'd also like to say, what I like to start with is to say, we don't always agree on the method to achieving our mission, but understanding what our purpose is, it sort of helps us to identify our common ground and allow each of us to keep an open mind through their discussions today. We will provide opportunities to share with each other. And my only ask is that we always keep this mission in mind, doing our best to keep our dialogue respectful and solution-driven. These photos, again, are individuals that agreed to share their images with us. And I think it's really important to highlight that we're here for people. I'm going to turn it over to Jordan for our housekeeping.
Hello, hi. I know many of us have heard this before, have participated in Zoom webinars, but it's always good to give a refresher. So this is a Zoom platform and this webinar is being recorded. So we ask that you please do not share any private information, including names or health data, either in the either spoken or in the chat. We do have a bunch of questions that we're hoping you will all answer, and we will also have time to take questions as well. If you have a question or you'd like to have your microphone unmuted, we just ask that you raise your hand to be unmuted. If you see at the bottom of the screen, there's a little button called reaction. So if you hit that, you can actually raise your hand. I'm going to do it now so you can all see it, and then you are able to lower it, and that helps us know. Or you can type into the chat and let us know that you'd like to be unmuted, and we're happy to do that. And if you have more information than you want to share here, or you have information that has protected health information in it, and you want to send us an email because you have specific questions, you can always send us an email to hss.dsds.policy@alaska.gov. We're always happy to take feedback, questions, comments, anything there as well. Thank you, Lynn.
Yeah, and I noticed that my caption box isn't always working when other speakers are speaking. So if anyone needs that for this meeting right now, please put in the chat or message one of our hosts here, and we'll repeat information if it's not showing up there.
Also, just to add to that, this webinar, since it is being recorded, will also be on the policy YouTube page, which will also have captions available.
Yes, good to point out, Jordan, that the YouTube page, you can always caption where we store all of our recordings. So we wanted to sort of highlight, we get a lot of questions about our regulation process and about when we reach out for stakeholder engagement, where are we at in the process? And people sometimes get confused because it is a lengthy process. So we wanted to make sure that we were able to tell you what what the process is and where we're at. So you can see here, Jordan put the slide together. It's a great slide showing sometimes we have an idea for a regulatory change. Then we go into stakeholder engagement before we have ever written any kind of a regulation. And you can see that's where we are today. We're at the stakeholder engagement piece. So we haven't drafted any regulations. We haven't done any work for that yet. Then we go into drafting. Once we get your feedback and your ideas, we will go into drafting, and then we will go out for public comment. You will have another opportunity to comment on proposed regs. In those particular sessions, we cannot do the back and forth. That's prohibited, but we do allow for you to give us your feedback, and then we can go back and see what we missed, and if we can change things, or if we need to do that. And then we put it forward, and it goes through the whole regulatory process for an effective date for new regulations. So we're still far way off from new regulations, and we're way back at the very beginning of first stakeholder engagement. I just wanted to make sure that everyone was really clear about what we're here and where we are today. So what do we hope to get accomplished? So I'd like to first explain a little bit of the history of why we need to make some of the changes. Review the timeline for the changes, a little bit of what I just gave you. I have another slide that talks about where we've been and where we're headed. And then give everyone an opportunity to offer us feedback. And again, this isn't really a webinar. Well, none of our webinars recently have really been to give you information. It's really to get information from you and help us to better meet your needs. So I hope you'll be very engaging today and feel verbal when we get to that section. So I just wanted to also talk about this timeline. I've included it in another slide. I updated it a little bit because I think the big question I've heard from a lot of stakeholder groups is, why does it take you so long to get this done? Why? We've talked about this for, since 2016. We identified a problem in 2016 for how we were setting up our family hab homes under provider agencies. And we went into a lot of work on an organized healthcare delivery system, which you can see in another PowerPoint, another recording that we did recently. But you can see we have a lot of start and stop times during our, well, you can't really see because the captioning's in front of it, I think. But we've had a lot of, like, we begin work, we stop work, we begin work, we stop work. We have these big things that have impacted all of us. COVID-19, we had people we lost in the pandemic. And we had the cyber attack, we had the earthquake, and I'm really not trying to make excuses. I just want everyone on the phone to understand that we shift and move with our limited resources to sort of adapt and blend, mold to those types of things. And we have to come up with an Appendix K, which is asking for flexibilities in our waivers. When each of those things happened, we did it for the earthquake, we did it for the pandemic. We're still actually in the unwinding and implementation of the Appendix K. And trying to then at the same time incorporate a lot of that stuff into our permanent work. So we recognize that there were some great things we did during the pandemic. We tried to make them more permanent. That all takes time behind the scenes. So where are we at today? We're at that red bulleted item, and we're going to talk about the service definitions for group home and family hab home. And I think this has been a long time coming from some of our work with our organized healthcare delivery system, reviewing what it takes to be a family home versus a group home. And that's why we're very excited to talk to you. We want to hear from everyone today. And then once we get your feedback, we will review all of those comments, and then we will go into trying to draft some regulations for redefining this. We have an opportunity because we have actually to open up our waivers to do some of the permanency work. And so this is a good opportunity, a good time to sort of try and do it together if we can. And then again, there will be another opportunity for you to do public comments on regulations when we get a little farther down the road. Well, before I move on, does anybody at SDS, you have any other things you want to say thus far? No?
Hey, Lynn.
Sure.
Yeah, I'll just say that uh, as Lynn said, this is an opportunity to hear your ideas on our ResHab services. And there are no bad ideas. There's no dumb questions. It's early on in the process. We recognize that we have a range of people probably on the call, almost 100 people. It's great to see such attendance. Some of you have been around for years and will know a lot of what Lynn is talking about. Some of you may be new, less familiar. But again, we want to hear from as many of you as we can, and don't be afraid to ask a question you may feel everybody else knows the answer to. And you know, because there's such a range of people here, and it's taken many years to get to this point. The division has been lucky to have Lynn as a steadfast presence, who's been able to witness some of the reasons why these changes need to be made. Some of these issues need to be addressed. So Lynn, I just wanted to stop and thank you for keeping these things on our radar and bringing them to the front burner today.
Thanks, Tony. Appreciate that. Yeah, I do have a long history with some of these and with a lot of you, so it's a good thing to carry that forward with the work. So one of the things that I did want to talk about today is when we talk about activities of daily living, ADLs. Oftentimes we say that a service like family home habilitation or group home habilitation must contain these types of things. So in our waiver language and in some of our conditions of participation, we talk about meeting people's needs for activities of daily living or instrumental activities of daily living. So I just wanted to highlight what they are for everyone on the phone so we get a level set that these are things that should be included in the family hab home or in the group home. And so, for instance, like with bathing, I took this really from just a basic definition, but is ability to clean oneself, get in and out of the shower or bath, perform other activities of personal hygiene, like shaving, brushing your teeth. Eating is being able to feed yourself, hold a plate, cup, be at the table, do all types of things like that. Dressing is ability to put on your clothes. It's pretty self-explanatory. Transferring is like on and off the toilet, perhaps, or in and out of bed. Those are all things that are activities of daily living. And, you know, I just wanted to highlight that. And, you know, individuals served in both of these types of settings, the family hab home and the group home, they're just that, they're individuals. So everybody needs a different level of help or assistance. Some need more, some need less, but they're just basic life skills that we feel should be included in each of the services. And so I just wanted to make sure we were highlighting those. These are instrumental activities of daily living. And when I say basic communication, that's like help using the mobile phone and email, the internet. Transportation is getting people to medical appointments, shopping, visiting friends, going to the museum, in examples. And these are all, again, a part of the regular basic things that we would expect either the family hab home looking like a family setting or the group home to have and be a part of, and their staff to be supporting individuals that live in their home or in the home, shouldn't say their home. So, you know, one of the things that I think we have always missed is that when I think originally when the department or the state decided to set up these types of services, in everybody's minds, they had this sort of continuum of care that there would be people living in their own home, perhaps with their parents. And as they grow and age, they might move from their family home to a different home where they're learning to live with other people that are in a family style situation. Or once they've graduated from that, or maybe they're living they learn skills, maybe they move to living independently, or they would move into a home with more of their peers instead of like a family style home. And I think one of the things that we have been missing is the way we describe the services themselves. And so wanted to sort of think through what a simple description, a paragraph, a simple description would be. And we sort of came up with this one. Doesn't mean it has to be set in stone, but I would really like people to think about what we're saying here. So it's a habilitative service in family home, meaning that you are teaching someone to either maintain or improve their skills. So that's what habilitation means. So, and a habilitative service provided in a family home, owned or supported by the primary resident of the home. And so people providing a family habilitation service, it is their home. They're inviting a recipient or a resident into, and they're incorporating them into their family and teaching them skills like a family would. How we put that into a definition is harder than it seems, because when you're talking about the primary resident, the owner, are they the owner, the operator? Do they own the home? Do they rent the home? Sometimes we don't care about that. We care about what it looks like, the service environment looks like. And so this is sort of, again, what we came up with. So they're cared for, the individual would be cared for as a part of the family unit while learning or maintaining their skills to become as independent as possible. And in the family hab service, it should include community gatherings, events, activities normal to a family, regardless of other services in the plan. So whether someone has day hab doesn't mean they're only sit in that home and wait for their day hab to come and they never get to go anywhere with the family. In my mind, I'm open to hearing what everybody else thinks about that. Would love to hear that. So that was sort of our description of what we thought maybe family hab would look like. Group home is a little bit different. Group home is shift staffed, or it's staffed differently. And it's, again, those individuals that are living in a group setting, they're learning to cohabitate and co-share with other adults in a home. And that's a normal, my phone keeps ringing, sorry. I'm interrupting myself. So that is sort of what our vision is for a group home. And they should be able, it's not the people, the staff's home. It is the people that live there. It is their home, and they get to say how they want that home run and how they want to be supported by the staff within reason, of course. But again, this should also include assistance to access community gatherings, events, scheduled activities, appointments, all of those things. So those are our best sort of ideas for a paragraph description of the services. But again, would love to hear from all of you. So these are some of the questions we have for you, and we're going to open it up now for your ideas. So the service environment, when we talk about what the service is, so they both occur in a licensed setting, but the service of family home habilitation or the service of group home habilitation, that's the environment we're trying to create inside of an assisted living home. So how do we write regulations to make sure family hab looks like a family environment? Like I said, it's a little more difficult than we think sometimes. And then how do we set rules to ensure group homes reflect sort of more of a roommate or a shared living situation where the home is equally reflective of all the residents of the home and not the staff of the home? And when I say this, I mean, I've gone in as part of quality assurance to a group home where the owner, that was the group home staff, was complaining about the person cooking their own meals in the home. And they were saying, you know, she keeps messing up my kitchen. It's like, it's her kitchen. It's not your kitchen. So that's a shift. It's a little bit of a shift. And I hope that we can talk about that openly, because I think it's important for us to recognize that not every provider is the same and not every individual's needs are the same. And so those are the types of things that we really need to be able to figure out how to regulate to, or set conditions of participation for.
Hey,
Does
Lynn,
anybody-
this
Oh,
is
go ahead.
Jordan. We do have a couple of hands up if we want to pause here, because I know we
Yay.
really would love to get feedback about these before we move on to the next. Spoiler alert, there are more questions that we have for all of you. So we would love to get feedback on just thoughts. What do you think about these questions? And we do have a hand up right now. I see Denise, you have your hand up. I can unmute you, or you might be able to unmute yourself.
Hi. Can you hear me?
Yes, we sure can.
Okay. I want to say that, I have a daughter that's disabled. She has behavioral needs, medical needs, communication. She's definitely a lot of work. And one of the obstacles that I have found is trying to find a place that would be appropriate for her. Whereas BAMHAB would be more appropriate for her because she doesn't do well with other people. She gets her agitated. The reimbursement rate for an adult BAMHAB is really there's just no way. No one would ever take her for the amount of care that she requires for the reimbursement rate that they would get for her. I mean, right now you guys pay more for a child BAMHAB than you do for an adult, and kids go to school, 9 months out of the year. So that for me is a huge issue. I mean, like right now I'm probably 50-50 where between burnout and needing her to go to a place, but her needing to go to a place would be trying to find the appropriate place for her. And BAMHAB would definitely be like the best. But again, the reimbursement rate for somebody like her, there's just no way anybody would ever take her. So that for me, I think is my biggest issue between the BAMHAB and the group home is the reimbursement rate.
Yeah, thank you for that, Denise. And I think we hear you. We have heard that before. I think the one of the things that I think we've heard loud and clear is that sometimes those family hab homes do need to hire a staff. So they weren't intended really to have any staff members. They were intended really to be a family home that someone comes in and lives with them, and the family or the primary resident, like we talked about, is the staff to that person. We recently have added through our Appendix K, adding flexibilities to the waiver, and we are working on making it permanent to allow an acuity level, meaning, if the person's behaviors or needs are so highly acute that they couldn't be served in a regular family hab home without an acuity, that we would allow acuity to happen where it's a one-to-one staffing pattern for that person in the home. That's really the only way that sometimes we are able to meet the needs of individuals, and we didn't have that before. So that might help someone want to serve your daughter, but that's a very good a good
Yeah,
comment.
I just feel like the individuals with the highest needs are the ones that would probably benefit more in the FAMHAB situation, where they can have a smaller environment, more intimate relationship with staff that gets to know them, but the level of care is really high. I mean, we're talking, medications and, if they've got seizures or other medical issues, communication issues, if they're nonverbal, changing diapers. It's like the amount of care that somebody like that needs in I think the reimbursement rate was like 46,000 or something a year for that type of care is just, there's just no way.
Mhm.
But again, the highest need individuals are the ones that would benefit more being in a FAMHAB in a smaller environment. So that's, again, that's my viewpoint on one of the issues that I'm seeing as an obstacle to try to get her the best care if she's not in the home with me.
I appreciate that. And thank you so much for your comment.
Thank you for allowing me to say this. Thank you.
Wow.
Thank you, Denise. We also have quite a few comments in the chat. I would love to, and if other people would like to come off mute and speak their comment, we're happy to have that happen too. We have a comment from Mary Hyman saying she's been told by agencies that they can't have goals for FAMHAB or outside of the home, like fairs and camping. If the family is supposed to have the client as family, it should include events. So more thought on what should be included in that. And then we have another comment by Nathan. If residential services are expected to provide community access outings and similar services, there need to be clear language indicating this, ways to track and ensure this is happening, and the reimbursement rate should make it a realistic expectation. Caregivers should be compensated for providing in-home cares and community supports. As it stands, this expectation is not happening consistently. We have a idea from Stephanie saying an idea, COPS for each service needs to be clearly written to include those activities that are provided under each service category. Plus travel regulations need to be rewritten to clearly outline how a person in a residential setting like group home or FAMHAB can use services to travel outside of their community. And we have a couple of people adding to that saying that allowing both to participate in overnight Alaskan activities such as subsistence, camping, outdoor skills are major asks when they talk about clients using those services. We also have a couple of questions, or at least one question about acuity being 24 hours. So it might be a good opportunity to talk about some of the changes we recently made to acuity. And finally, licensing requirements for FAMHAB are overly burdensome and difficult to have families who do want to do the service. So we are having some great discussions in the chat. We also have, I think maybe let's pause there for a second. And Lynn, do you want to speak to the acuity one first? I know that one we want to make sure.
We actually have another slide on acuity add-on. So I
Oh,
think
great.
I would hold that
Save
one.
that one, hold on to
I'll
that.
talk about
Okay.
that one then. I see Tyler has his hand up in the
Oh, yeah.
chat.
Great.
Tyler, do you want to unmute? Tyler McNeil, can you unmute? Maybe not.
Well, maybe while Tyler is working to unmute, we also have someone in the chat. Looks like Cheryl. Cheryl would like to come off mute. Cheryl, are you able to?
Hi. Yeah, and hi, Lynn. And I'm, and I'm coming from a lot of experience with this. And, I guess my question is, I've never understood why the family habilitation homes are not, the first question is why they're not compensated at the same rate that a therapeutic foster home is. Having the history with therapeutic foster homes, having history with family homes, FAMHAB homes actually work harder in a lot of ways than a therapeutic foster home. But the therapeutic foster homes rates are like 280, 290 a day. So I am not understanding why that's not comparable. That's the first question. And the second question is the challenges that we had. There's such a huge need for FAMHAB homes, and the challenges that we experienced when I was working as the nurse manager for OCS is that I know that there was a concern from SDS at the time that the FAMHAB homes had to be their own entity. And the homes didn't want to do that. It's a lot of work, it's a lot of issues, but yet you have behavioral health who has agencies that have the therapeutic foster homes. So why is it that and they're getting paid more, but yet they have an agency managing them. So why is it that STS can't structure in the same way? I mean, we personally, as an agency, I would definitely be willing to bring on FAMHAB providers and be managing of that agency, similar to how behavioral health does it. But that's not something, you know, that apparently is something you guys are interested in, from what the challenges that we had in the past with like bigger agencies that were doing it. So
Well, it's not a matter of, well, I'm sorry to interrupt. I'll let you keep talking, but I want to go back.
no,
to-
you're okay. You're okay.
So that's an organized healthcare delivery system that we are creating. And
Okay.
we have to do that. That's a part of how the federal money flows through for Medicaid. So behavioral health may do it a little bit differently than we do it. They may have different oversight. I'm not sure about that. All I know is that we have to do it. And so that's what we're working on now. I have another webinar that you could go and look at that we recorded a couple weeks ago on organized healthcare delivery systems, OHCDS.
Yep, I saw that.
And that should answer some of your questions. As far as the payment structure goes, there's a lot that goes into those individual rates. So a therapeutic foster home, I'd have to take a look at that, but I would imagine there's a lot of there may be a different clinician level. I'm not sure. There may be different treatment that they're supposed to be providing. I'm not sure. We could take a look at that, but
but is there a chance? I mean, and I'm just asking questions because, you know, I'm looking, I get it, and I understand that the huge challenge and need for FAMHAB. So is it a possibility that it can be something that can be submitted for Medicaid waiver, so that it could be structured in the same way?
It is under Medicaid waiver. So the family hab homes are paid for under Medicaid waivers. Therapeutic foster homes are paid out of a different
behavioral health, right.
way.
Yeah.
Yep. Thank you. Tyler, were you able to come off mute?
Yeah, sorry about that. I was having technical difficulties. It was not letting me unmute, but hey, I appreciate it. I was really happy to hear you say, Lynn, earlier when you were talking about, you know, not wanting recipients of family habilitation home services to be sitting around the house waiting for their day hab to be able to get out and about and engaged in the community and activities. And I just hope that that's a theme and a discussion that continues to evolve and expand in the residential habilitation services in general for all of them. You know, I think about the regulations here when it's talking about provider certification. It says a provider certified to offer the following home and community-based waiver services shall render those services in a setting that is integrated into the greater community and that allows the recipient to access that community to the same degree as an individual that does not receive home community-based waiver services. And then it goes on to list all of the home community-based services, including residential habilitation. And I know the intentions from Medicaid certainly see fully integrated, inclusive lives for all of our recipients through all of the home and community-based waiver services. And at times we have experienced resistance around the topic of services like supported living being provided in community public settings. And there really isn't anything in the regulations or in the technical guide, the Center for Medicaid and Medicare Services technical guide for residential habilitation that warrants that resistance. And in fact, the settings rule that came from Medicaid, and I believe it was maybe 2017 or 2014 that it rolled out, but the settings rule is very explicit about all of the home and community-based waiver services supporting fully integrated, inclusive lives. And so I just hope that language and that idea is expanded through all of the residential habilitation services, group home, family home habilitation, in-home, and supported living. And so I hope that that conversation continues to move forward.
So just one comment about that I can think of. I appreciate that, Tyler, and your eloquency and saying that. One of the differences, I think, and I would love to have a more in-depth conversation on this. One of the differences is that supported living is not really intended. It's a 15-minute unit for inside the home. It's not intended for community living, even though it's a part of residential habilitation. So that would be where I think we would have a little bit of the stickler happening. When we look at those, we don't have like a supported living like we used to a long time ago, like a 4-hour unit or 8-hour unit. It's really intended to be a teaching skills inside the home for maintaining the home. But saying that out loud, could that include shopping? Could that include something like that? That is something I think that we could take back and definitely look at. And if you have, more detail on what you would like to see, we'd love to see that from you.
I really appreciate that. And yeah, the Center for Medicaid and Medicare Services technical guide does state under the residential habilitation umbrella, which includes supported living, that these supports include adaptive skill development, assistance with activities of daily living, community inclusion, transportation, adult educational supports, social and leisure, etc. So it kind of goes on with the list. And it does further on say residential habilitation services may be provided in the participant's living arrangement or in the surrounding community. And so I think that's really the heart and design for the home and community-based service program as a whole, and certainly all of the residential habilitation services. And I think the only hangup that has caused the confusion with the state of Alaska is in some language in our condition of participation that talks about the service primarily being provided in the person's home, but being able to be provided in the community in certain settings, or because some skills development may be enhanced by activities in the community settings, right? So the condition of participation does have some language that causes some hangups, but overall, I think the message is clear that those supported living services should include regular home and community living supports and should not, be limited to the person's home, because that really leads to isolation, and we don't want that for anyone.
True, we do not. I think when you're looking at CMS guidance, the only caveat I would say to that, and I'm not trying to be a naysayer, because I personally wholeheartedly love the idea of community inclusion and making sure that we're using the services in the best way to support a person to lead very independent, inclusive lives. But CMS writes a lot of that guidance as a general may include or may blah, blah, blah. And they defer to the states to set up the rules around that. And so that's the part I think we could go back to that technical guidance, and we could challenge ourselves to rethink those rules in the future. So I just want you to know that it's not like CMS is saying you have to do this under residential habilitation, because they always defer to the states. We have the ultimate sort of say in what happens with that.
Well, I appreciate the clarification, and I think that while we're looking at these regulations, it's a wonderful time to reevaluate our priorities in that area.
Couldn't agree more. Really appreciate the comments. Thank you, Tyler, and thank you, Lynn. I know we do have a couple more slides with more questions. So I want to encourage anyone who has more thoughts on service environment to either put them in the chat or to send an email to that policy email, because we really genuinely want to know what you think about these questions. How it's tough to write something that is both clear enough and flexible enough for everyone. So we're interested to know your thoughts on how we make sure FamHab looks like a family environment, and how we ensure that group home reflect a roommate situation where the home's equally reflective of everyone. So please, if you still have thoughts on that, send it to the policy email. But in the interest of time, if we could move to the next slide, that with a couple more fun questions.
Yes, I just have one more comment on this slide before we go.
Sure.
Thank you for that, Jordan. I just also want to say, when we're developing regulations, we all know that all people are not created equally. All providers are not created equally. So when we're writing regulations, we also have to think from a quality assurance perspective. How do we make it clear enough that if people are not doing it and they're not providing, let's just say they're not providing access to the community, how do we write it clear enough that we can actually do something about that? And so we can't have too fluffy of language. We have to have pretty clear guidelines. But I just want you to think about that as well, because I know everyone has, great stories and then not so great stories. And we have to sort of, as a state, come down the middle and care for both of those. So our next slide is staffing. So we have never really said in our regulations that there has to be a certain amount of staffing in the home, a staffing ratio from staff to residents in a home. But should we? That's the real question I have for folks out there, because I think one of the questions, and it's really difficult right now because of staffing shortages sometimes, but one of the questions we have is if people are understaffed in a home, and then again, it causes people to sit and wait for their day hab person to show up, or wait for someone to come and assist them because the group home itself does not have enough staff to do it, or they don't have enough staff to facilitate it. We'll talk a little bit more about that in a minute. But I'm just wondering, I'll stop talking for a minute. Does anybody think that we should have a regulation to say how many staff must be per resident when we're talking about group home? Not seeing anything yet.
Denise, is your hand up again? I didn't know if that's from earlier or a second time, but
It is. It's up
oh,
again.
perfect. Oh, great.
Oh.
Yes, jump on in.
I just wanted to comment on the number of staff, and I think that's a really great idea. I will say that I do know personally of some instances where individuals have been in a group home and they've really required one-on-one, and there's only been one staff in the house, and they were unable to get staff, and they have literally been stuck in their house for months because she can't go anywhere. They require one-on-one. So I do think it's really important, not that the staff reflects the clients that they have. So if they require one-on-one, then they need to have staff for each individual client. Because like I said, otherwise it really restricts their life and they can't go out in the community and do anything. So that's all. I just want to again talk about the staffing in group homes, and that it is really important.
Thank you, Denise. Kim.
Super quick. And it builds on some of the comments in the chat. I agree. I think a number is very, very challenging. And, if there was a way to do some assessment, even maybe through the NRI tool that you guys are looking and shopping around, or some expectation, because I do hear a lot of stories of homes that don't have enough staff to meet the needs of the people living there. On the other hand, you don't want to overly staff a home, especially when there's a workforce shortage. And how does technology come into that? So that's where the fine line is of like, how do you hold people accountable? So there should be expectations, but maybe something to think about related to the NRI. Thanks.
Thanks for that, Kim. And so the NRI is for folks on the phone is an assessment tool that we are transitioning to. We're doing a lot of work. We received some money from the legislature, and part of that is because we need to implement the tool first, the actual assessment tool, but it allows us to establish resource allocation. And what that means is that, like I said, everybody's needs are different. It allows you to sort of say with a little bit more pinpoint accuracy where people fall into a tier and what they might benefit most from, or what resources they might need. And by doing that, we're also able perhaps to allow different levels of acuity may require different types of homes, different types of staffing levels, there are lots of things that can come with resource allocation. And so it is something that we are definitely pursuing, and we're, takes a long time to set it up, but we're working hard at getting the INTRI going. So just for background information for folks on the phone. And then there's some comments in the
We do have
chat.
a lot of traffic in the chat about this topic, and I think it's pretty split. We're seeing people say yes, definitely. We're seeing people say no, absolutely not. Every client has different needs. Every home would have different ratios. So there's something to be said for Kim's comment about the individualized assessments. But
and just so folks know, that's probably why thus far we haven't done it. Because there's a lot of thought against it. There's a lot of thought for it. We try to come somewhere in the middle to say you have to meet the needs of the people, but it is difficult all the way around. I think I'm going to move on to the next slide because it's related.
Yep.
What rules should exist for staffing a group home versus a family hub home? Should it be different? Reminder that we think of the group home as being more of a shift staff. People are supporting individuals in a home, more individuals, where family is more of a family type setting. And who should be able to live at each one of these homes? Should there be criteria for acuity? Maybe, I'm just going to throw this out there. Maybe some individuals have too high of an acuity need to live in a family hub home and should be served in a different place. The INTRI assessment might help us pinpoint what some of those could be in the future, but what do folks on the phone think about that? And should they just be able to choose? I've heard recently that people are choosing to move from an independent living situation to a group home situation. And there's a lot of discussion about that. And I just want to say publicly, we have very little control at the state about whether that happens or not. So a person, once they're on a waiver, can choose different services in the waiver. And if they want to access a group home and that's their choice, we don't prohibit that. So I've heard recently we should have an acuity level that says you have to reach a certain point before you could move into a group home, because we're seeing people that are very high skilled individuals that are moving into those settings for various reasons that I'm not aware of. I don't know all the reasons for that. But those are some thoughts that are floating around, and I would love to hear from people on the phone about that. What do you think about that? Kim?
Yeah, I was just trying to type this in the chat, but it's easier if I say it. I wonder if it would be so wonderful to build a continuum of care that's very, very clear, because we haven't talked about host home, but I think sometimes people don't want to work on goals every day for the rest of their life, right? People want to live with a family and their needs are, you can just fit in with a family, and that's the host home that you're building. And then you go to family hub, and that's somebody who doesn't need a lot of extra services necessarily, but wants to be part of a family. But they should also have day hab so they can take a class if they want to. That's separate than a family outing. And then you move to group home. But then we need specialized group home or specialized family hub plus acuity for, like Denise was sharing. Yes, a family hub wasn't designed for someone with very, very highly complex needs, but there are people who need to live in a family home setting who have very complex needs. So then you guys have built the specialized family hub, but so important. And I know you know this, but this is where our advocacy comes in. they have to be well funded, because the rates don't pay for the service, the right service, right? So Family Hub, if you only have Family Hub, it's only one rate, then you're going to get people who really need group home but should live in a Family Hub. But if you have a specialized Family Hub that really pays a much higher rate for people with highly specialized needs, well, then you have an actual continuum of care. And so it's exciting to see these pieces kind of coming together, but I keep thinking about like, wow, there's this continuum, and can we really define it? And then use the COPS, like several people have said, Stephanie, to then talk about the details around like, what does that service really look like? And does it include transportation? Because that's group homes. Should they provide transportation to and from things? They probably should. But if you have a group of people and you don't have somebody to drive, anyway, I don't want to take up too much time, but it does feel like we're starting to get to the point where we could have a real continuum of care.
I appreciate that, Kim. And I think that's exactly sort of why we're having this conversation, because I think we all see it and feel it and want to be able to create that. There's a lot of steps and parts and pieces to that have to go together. But I do think, I hear from people a lot. And I think that's what we're hoping to see, happen in the future. Shane?
I think also there's these personal choice elements of, they know someone who's in that group home or at that Family Hub home, or they maybe don't want to feel like part of a family. They want something a little less, I mean, just they have these choices. Or down here in Homer, hey, they need something other than an independent apartment, and there's one opening at one group home, so there's just these limiting factors on choices, and then personal choice as well. That's where their friends live, or they like these people over at that.
Yeah. Sorry, you cut off there at the end there, Shane. I think I have heard also from some guardians that they feel safer, that I think it's probably a little bit easier to have people served in a group home because you feel like there's more staff there, there's more eyes on. I'm not sure all the reasons again, but I think if we were going to move to this sort of continuum of care, we'd have to have that hard conversation, because not everybody would qualify for a group home anymore, and not everybody would qualify for a Family Hub home anymore. We would eliminate probably part of the choice for that, because you would have acuity levels and you would fall into whatever type of tier you are. So because as soon as you take that away, that's where we're at right now. Anybody can choose anything. And I don't know that it's always promoting the most independent setting for folks. And that's the troublesome part, I think, to me personally, when I think of the work that we're doing to try and make everybody's lives as inclusive and independent as possible. Sometimes we create these little tiny barriers.
Hey, Lynn, this is Jordan. I know we have a couple of hands up, but we are running low on time here. If you want to just do the next 2 slides, and then we can use the remaining few minutes just so we have these questions out into the ether for people to noodle on and get back to us. I think would be good if you're comfortable moving forward.
Yeah, I think it's great. I'm so happy to have so much conversation. It's so good. Let's see, where are we at here? Staffing, we already talked about that one. So acuity add-on. So this is what I was talking about earlier, where we recently added acuity to family home habilitation. And this one is a little bit of a tricky one for us, because a lot of Family Hub homes, like we said before, don't hire staff. So hiring an acuity staff, the way it is currently set up, if you're independently certified and enrolled, you can hire staff, or you have the ability to bill for acuity. If you're working through an agency right now, in the current day, that agency would probably have to be hiring the acuity staff because they're the ones that bill for that service. When we set it up for an OHCDS in the future, that may look different. So I don't want to take up the whole time today to talk about that, but we do want to be able to allow some acuity in family hab home. The other thing that we've talked about that Kim mentioned is that we have added is a specialized family hab home and a specialized group home, which we're pushing forward to make in our permanent waivers. We have it approved under Appendix K, so providers could apply to be those types of providers. There's some special requirements for that, and the rate is much higher than our normal group home, or definitely much higher than our normal family hab service home. But I'm wondering, we just wonder about the rules in our, as we go forward, what should they look like? How should we think about those acuity add-ons? And remember, right now in our system, acuity add-on means it is paired with either family hab service or group home service, or we also have an acuity add-on for residential supported living on our ALI waiver. There's no acuity level for just adding staff to a person's waiver for a few hours. That doesn't work. We did take the 24-hour unit and we split it into 3 8-hour units. And we did that because we thought that's how we heard from providers. That's how they bill for that 24-hour unit. But the acuity is really only intended for people that have a high level of service need. So I'll skip to the next one. Again, when we talk about providing access to the community to accommodate someone's needs, it doesn't always mean, at least in the way we've sort of drafted the language, or not drafted the language, but in maybe our settings language, which is in rule, we talk about facilitating access to the community. And that could mean that I teach someone, I'm a recreation therapist, so I always think about the teaching part. I teach someone to get to the bus stop, to get to their job. I don't necessarily have to always take them to their job for the rest of my life as a group home person. I might work with other individuals that are going to that same job to get a ride. I don't know. There's just, facilitation is different than providing necessarily. But just wanted to talk to you guys about that particular thing. And I think we got a lot of comments in the chat already about that, which is awesome. And I think that is one of the biggest things, like how do you set that in rule so it's flexible yet
Clear.
Clear. Yeah.
Mhm.
And stringent enough that providers do it. They either facilitate it or they provide it. Questions. Let's go back to questions. How much time do we have, Jordan?
We have, 2 minutes generously.
Oh my gosh, that went fast.
It went
Sorry.
very fast. It was such great participation, and the chat is really, just to let everyone know, we are seeing all the comments in the chat, and we're going to be able to take that and take a look at it after this. So we really appreciate it, and you again can always send us an email if there are more thoughts that you had. But if we have another minute or two, if anyone wants to come off mute and say anything, I would be happy to hear.
I saw that someone actually put in there, they wondered if we're going to a tiered service delivery system. That's not necessarily what we're doing, though resource allocation will help us pinpoint that. And that is work that will happen several years from now. Unfortunately, we have to implement the assessment tools first. And then I think we're going to have a lot of conversations about that. But does anyone else want to say anything while we have another minute?
And I see a couple comments saying, this conversation would be great to continue. We completely agree. we've been having kind of a series of webinars as we move through different regulation projects through the division. And again, this is a conversation that always can happen and can always, you can always consider yourself in conversation with us. Feel free to send us an email. I'm happy to arrange time to chat also. I know Lynn would be too. And
Absolutely. Anybody that wants to call, I'm happy to hear from you. And we always encourage things through the policy mailbox, because then we can tackle it as a team and look at it, which is sometimes better than getting one of us. But thanks so much for everybody's participation. Totally appreciate all of you and your coming together to talk about this. It's really important to us.
thank you all. Happy Friday.
Happy New Year. Take care.
Happy New Year.
Mhm.